Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Thank you very much indeed. It's a pleasure to welcome our next speaker. Anna Lowe, I think I'll get her roles right, is currently Programme Director at the National Centre for Sports and Exercise Medicine in Sheffield, but has a more complicated backstory which she will explain involving Public Health England and the NHS cancer work. So, Anna, really looking forward to hearing you speak. Thank you.
Oh, hi everyone. It's great to be here this morning to talk to you about personalised care and how we can align personalised care with prehabilitation. So, as you know, I'm Programme Manager at the National Centre for Sport and Exercise Medicine, newly appointed there. I'm also Lead Allied Health Physical Activity Clinical Champion for Public Health England, and I'm going to come back to that role shortly and tell you a little bit more about that. I was invited here today because I spent a period of time working for NHS England in the National Cancer Programme team within the Living With and Beyond Cancer team there. So in that role, I followed the development of the prehabilitation guidance very closely from a kind of policy angle. So I'm going to be sharing some of my thoughts and based on the kind of information that I was exposed to when I was at NHS England, but I need to make it very clear that I'm not speaking on behalf of NHS England today. And as several people pointed out last night, as I no longer work for them, I can say whatever I like. So, great. So in terms of policy drivers and cancer prehabilitation, there are many, many policy drivers. I'm going to focus on the long-term plan because I've only got a short amount of time and it's a really big critical document. But I want people to be very mindful that there are broader policy drivers from Royal Colleges, from third sector organisations, from other arm's length government organisations, PHE, Health Education England as well. So, but I am focusing on the long-term plan. So in case anybody's not familiar with the long-term plan, I'm aware that not everybody's from England here, so it is a key seminal strategy document that came out last year. It doesn't replace the 5-year forward view, but it builds upon the 5-year forward view. So just to recap on a number of key elements of the long-term plan. Some of these are discrete areas of focus and some of them are threaded through the long-term plan. So first of all, personalised care, and I'm going to come back and talk about that because that's the focus of this session. So I'll return to that shortly. Prevention is very clearly highlighted as an area of focus in the long-term plan. It was in the 5-year forward view as well. And I think it's fair to say that it was one of the areas of the 5-year forward view that possibly failed to gain as much traction as people would have liked. So there's renewed ambition around embedding prevention into healthcare, and there's some very specific deliverables around obesity, around nutrition, around smoking, around alcohol. So cancer is a clinical priority. It's one of the named clinical priorities within the long-term plan. If you look at the cancer-specific content of the long-term plan, it is largely focused around earlier diagnosis, faster diagnosis kind of treatments, with a bit of a mention about living with and beyond cancer as well. Content of the cancer section is quite limited, but the whole of the document contains a huge amount of information that's very relevant to delivering cancer care and delivering prehabilitation. So there's a huge aspiration around digital and digitising the NHS in terms of the infrastructure that we have access to, but also in terms of integrating new technology as well. And then integration and collaboration is a consistent theme throughout the document and is really seen as mission critical to the transformation that is that's desired. And that's integration between primary care and specialist services, integration between physical and mental health, and integration between health and social care more broadly as well. So I'm going to just focus on personalised care. So personalised care is a really key component of the long-term plan. I think it's the first time I've seen such a commitment to making personalised care a reality and changing it from something that is that's possibly been seen as a bit of a nice to have, and absolutely networking it into the system and making it business as usual. So it's a very clear focus. And the reason for that focus is in part because of the changes in population and demographics that we see across England. So we know that currently people with long-term conditions currently make up about 30% of the overall population. They account for about 50% of all GP appointments, 64% of all outpatient appointments, and people with long-term conditions occupy 70% of all hospital beds. So if we think about what's happening, if we kind of compare that to what's happening with life expectancy, we know that approximately 50% of babies born today will be expected to live to over 100. So we're living longer, but we're living longer with a greater burden of disability. We're acquiring our first long-term condition earlier in life, and then gaining more and more long-term conditions as we go. And there's been some really interesting work on the sequelae of those accumulations. So of the current population aged 65 or over, 15% are either moderately or severely frail. 7 out of every £10 of health or social care budget is spent on supporting people with long-term conditions. And by 2035, 2/3 of adults are expected to be living with multiple health conditions, and 17% of the population is expected to have 4 or more long-term conditions. So that the population is very definitely changing, with living longer, with a greater burden of disease, which has a huge personal cost and impact on individuals, their families, their carers, their loved ones, their ability to do what they enjoy in life, their ability to work, and ultimately that kind of economic burden as well. So the other part of the case for change around really focusing on personalised care. So there's a statistic that's come out of a document that I'll show you shortly. So only 40% of adults report that they've had a conversation with their healthcare professional in their GP practice to discuss what matters to them or what's important to them. So we're missing opportunities to really kind of hone in on what matters to that individual, and to really tailor care around individual people. And then in the green box, only 55% of adults living with long-term conditions feel that they have the knowledge, skills and confidence to manage their health and well-being on a daily basis. So almost half of people with any kind of long-term condition acknowledge that they could, with the right support, manage their conditions better. And if we just flick back to the previous slide and think about the cumulative burden of long-term conditions, if we can activate that 50% or 45% of people to manage their own long-term conditions better, then there's potentially huge impact there. So part of the long-term plan really focused on personalised care, and shortly after the long-term plan was published, this document, Universal Personalised Care, came out, and this really talks about how this is going to happen in a great amount of detail, and the actual specific actions that are going to lead to personalised care becoming business as usual. So rather than talk through this, I'm going to show you a very short animation that just summarises the key elements of it.
What is personalised care? Personalised care is where people have more choice and control over how their health and care needs are met. It recognises that people themselves can sometimes be the best integrators of health and care, and supports them to live as independently as they wish. With personalised care, people are more involved in the decision-making process and should be supported to talk about the things or outcomes that matter most to them and what is the best course of action to achieve these outcomes. The result is better health and well-being for them, plus more effective and joined-up services. People are able to develop their knowledge, skills and confidence, and can take on as much responsibility as they want to manage their own health and well-being. But people will not be left on their own, and the NHS will be there to support them as it always has done. As we move towards a more personalised system, it is important to have a clear approach as to what this means, and that is why we have established the new comprehensive personalised care model. This is an all-age, whole-population approach to personalised care. It focuses on helping people to achieve better health and well-being outcomes by assessing specific personalised care, support or interventions. To start, the whole population can be supported to stay as well as possible through building community resilience and enabling people to make informed choices when their health changes. There are a number of universal interventions which help to achieve this, including shared decision-making and patient choice, and social prescribing and community-based support. The next group are people with long-term physical and mental health conditions, who make up around 30% of the population. A personalised care approach supports these people to build knowledge, skills and confidence to better manage their health and well-being through a series of targeted interventions in addition to the universal interventions. These include personalised care and support planning, and support to self-manage, which includes health coaching, self-management education, access to peer support and use of the patient activation measure. The third group are people with complex needs, who typically have multiple long-term conditions and who make up around 5% of the population. A personalised care approach provides intensive specialist interventions to empower people and integrate their care and support so as to reduce unplanned service use. These interventions include the targeted and universal interventions, as well as personal health budgets, integrated personal budgets, and integrated personal commissioning, which enables people to take direct control of the resources available for their health and care. Acknowledging people as experts in their own lives, health and care not only adds value to people's lives and experiences, it creates value for the taxpayer and better integrates the system around the person. The comprehensive personalised care model demonstrates how this more personalised approach can become a reality. If you'd like to know more, visit england.nhs.uk.
Thank you. If we could just switch back to the slides, please. Thank you. So hopefully there's some very clear parallels between the aspirations around personalised care and how prehabilitation's being organised and planned and delivered. At a kind of face value, the fact that both the stratification model is key to both prehabilitation and to personalised care, really demonstrates a commitment to moving away from this one-size-fits-all type approach to really have a better differentiated offer for patients. I've got a couple of quotes here that I think really sum up some of the overlap and some of the synergy between prehabilitation and personalised care. So the first one is from Macmillan. I think it came out of some of the insight work that was early on in the development of the prehab guidance. So prehabilitation helps you pick, edit and contribute to your own cancer story, so you have your own ownership and don't just feel you are being done to. So I think that's incredibly powerful, and it shows that the desire to have control and to be able to influence your own care in its planning and its delivery. And then the second one's from the Personalised Care document. So personalised care means people have choice and control over the way their care is planned and delivered based on what matters to them and their individual strengths, needs and preferences. So really a big move away from the one-size-fits-all, asking the patient what matters to them and tailoring care around them. So I just wanted to talk for a moment about some of the things that I think are really relevant from the work that I've done from my role at Public Health England. So I'm a physical activity clinical champion for Public Health England. This is one of the programmes that Sarah touched upon. It's a parallel work stream to the Moving Medicine piece of work that we've just heard about. So there's a national network of clinical champions. There's about 25 of us, and our remit is to deliver physical activity training to as many health and social care professionals as we can possibly get our hands on. So between the 25 of us, we've delivered training to over 20,000 health and social care professionals now. I've personally delivered training to over 1,000. And so we've learned a lot about what clinicians feel about talking about physical activity to patients, and I just wanted to share a couple of insights with you there. So firstly, to echo what Sarah said, clinicians often feel that they don't have the technical knowledge to talk credibly about physical activity with their patients, and that's something that is absolutely staggering to anybody outside of healthcare, because they just can't understand why that's a problem and why that can't happen. But as Sarah mentioned, there's been a number of surveys that have looked at different professions and their confidence to talk about physical activity with their patients. These have been replicated in different professions and in different workforces, different healthcare systems across the world. So this is a common finding. We've also found that even when clinicians do know what they want to say to patients, they lack confidence that they can actually arrange that information in a way that's most likely to yield behaviour change in their patients. So although they have the technical knowledge, they lack, we often hear that they lack confidence to put that information in a way that's meaningful to patients, and particularly thinking about behaviour change theory. So I think it's really important that as prehabilitation programmes develop and evolve, that keeping those things in mind, that this might be challenging for clinicians, this might not be straightforward for people to have those conversations, is really important. And clinicians very often want to talk about physical activity with their patients, but just feel that they are swimming upstream and that their events are conspiring against them with it. So things like the fact that your clinic's running late, you've got a full waiting room outside, you've run out of leaflets, all these little things that add up to just make it easier to actually not have that conversation. And one of the things that I think is so great about prehabilitation is that it's moving away from asking individual clinicians or encouraging individual clinicians to do things differently, and it's reorganising the whole system around them so that you hopefully stop feeling like you're swimming upstream with it. And then my last point on this, as a reflection from the physical activity clinical champions work, is that we need to create consistent messages that are simple and are easy to reinforce. And there was an example before about the damaging messages that rest is best. And it's still, it's relatively common to hear patients coming in and saying that they went to their GP and they were told to go and rest at home before their cancer treatment starts in 2.5 weeks' time and get their strength up ready for treatment. And we know that that's exactly, not the message that we want to be spreading. So just a very quick plug for the Physical Activity Clinical Champions training. It's free. If you're in England, our network of Physical Activity Clinical Champions will come to you at a time and a place that suits you and deliver free training. And if you are thinking about implementing prehab in your own area, then it's a really great thing to do to just kind of soften the ground and get people on board with these messages. And we're going over to Manchester in September to deliver to the wider team there. So I'm looking forward to that. So just to summarise, in terms of the long-term plan and prehabilitation, there are a whole load of facilitators in there. There aren't any red lights. I know that a lot of people in the room would have loved prehabilitation to be mentioned by name in the long-term plan, and it isn't, but it's mentioned in everything but name, I think. So there are so many green lights and things that are very much aligned with prehabilitation. I think as prehabilitation programmes around the country and around the world evolve and develop, I think the closer that you can align your plans with the prevailing policy documents in your own area, then the easier it will make your life. And I think even down to mirroring the models and the language that's used just helps to get decision makers on board. So the ambition with the long-term plan and the ambition with prehabilitation is to really change the architecture of choice around patients, change the architecture of choice around clinicians, to make it easier and to really move away from this feeling of swimming upstream when you're trying to embed healthful behaviours into healthcare. We're trying to plumb it into the system. It's not about, hopefully we're moving from kind of small scale pilots into absolutely making it business as usual. And I really hope that as we continue on that journey, we can really make personalised care front and centre throughout. Okay, thank you.
Top Med Talk. Nick Majerison here. Thanks for downloading Top Med Talk. Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.